Proceed.
Alrighty, I have the recording started here. So here we go. Alrighty, I hope everybody had a great Monday. We're gonna get right in, and this is kind of my favorite part of the the stuff that we talk about, because this is when we actually talk about, the eye diseases. And I know we just literally began, we talked about some of the, a lot of the structures of the eyes and everything like that. So now we're going to dive in and actually talk about the eye diseases and why these diseases, number one, what they are, what I feel are the important ones, and number two, what is going on that's actually causing that person or your client to actually lose some vision. So without further ado, we are going to hop right in here. So, alrighty, so first up, we're going to start. I've kind of got this aligned with how things go through the eye from the front to the back. So I have different structures. We're going to be talking about the blur for the next 2 weeks. So different things that cause blurred in a patient vision. This is not talking about glasses or anything like this. This is actual visual impairments and whatnot. So we're going to start in the cornea because, again, that's that first structure that comes through here. So the first thing we're going to talk about is keratoconus. So keratoconus is a developmental abnormality of the cornea that has a general onset in the teenage years. It happens bilaterally, which means it happens generally to both eyes. It's very rare for it to occur with just one eye. It does happen in females more than males. No, we don't know why, but that's what we tend to see. And it tends to be more associated with people that have hay fever, atopic dermatitis, eczema, or asthma. And so what happens is basically the cornea progressively thins. Now, when you think about it, if you think of like a balloon, and as you blow a balloon, that material, the latex or whatever the balloon is made out of, gets thinner and thinner and thinner. And in that spot, it basically causes the balloon to expand. Well, the cornea does kind of just that. In that spot where it gets thinner, it kind of bulges out and creates a cone, hence keratoconus. This is a cone that kind of bulges forward. So that's why it's kind of named that. We're not talking like a cone from like the cone heads way back in the day, but this is just a general, kind of cone pushing out. It's not a spherical shape anymore. So this creates irregular astigmatism. Don't worry if you don't know what astigmatism is. We'll discuss that later, but I do want you to know that it creates irregular astigmatism. And anytime you see the word irregular astigmatism, we can't correct that with glasses. So there's got to be something special that we do, whether it's a hard contact lens that uses the tear film to kind of correct the vision, or we have to do a corneal transplant. That's what a keratoplasty is. There are some new things out there called corneal cross-linking. So this is a special procedure that can actually strengthen the cornea now, which is pretty darn cool. The fact that we figured out how to strengthen it, so therefore the cornea doesn't progressively thin and make this cone larger, worsening a patient's vision, because once it gets there's a certain point to no return where the cornea does start scarring. And obviously, if there's a scar, that means there's an opacity, there's something clouding the cornea, and that's going to drop the vision dramatically. So it doesn't matter what you do with contact lenses or anything. The vision's been permanently reduced unless you're actually going through and, just replacing the cornea. And so to replace the cornea, this has got to be somebody that's died and donated their body to science. So that's where that, shared cornea is. And then that cornea has to be removed successfully within like 24 hours and then put on ice. Otherwise the cornea is gone. So anyway, there's a lot of complexities in that here to let everybody know. And then obviously we may have to use low vision aids if none of the above work, because that vision impairment is now to a point where there's nothing optically we can do. So we need to use some type of special low vision aids or magnification. So that's keratoconus. Next up, we have herpes simplex keratitis. This is an inflammatory disease that literally comes from the herpes simplex virus. You may have heard of those. They have a little thing may have a cold sore on their lips. Well, this is a cold sore on the eye. I did see a question from the chat. Give me just a second. So Kimmy, it depends, number one, on the surgeon. Obviously, a corneal transplant, it's like any surgery. So, the question is, do you recommend it? Because they didn't have it. Um, there's so many different factors that go in. Obviously, if you're at the point where a surgeon is recommending it, they don't do these willy-nilly because we don't have a abundant supply of dead people's corneas. So they're not going to recommend it unless they're a good candidate. And again, it doesn't always work. So honestly, I leave it up to the surgeon and the patient to decide what's best for them. So I hope that kind of helps out there. So back to herpes simplex keratitis. This is a type 1 herpes. So that means it's waist up, because there are cold sores that can happen downstairs and that becomes an STI, and that's type 2, which again, yes, it can happen on the face, but that's a whole nother segment here. But again, basically, we're all exposed to the herpes simplex virus almost before the age of 1, because what happens when you're a baby? People kiss your face. And they may not know it or not, but if they have a cold sore, or maybe that's one that's developing, all of a sudden it's going to shed its viral particles onto your face, and boom, you've got it forever. It's amazing. It's the gift that keeps on giving. And so this virus goes dormant in what's called the trigeminal ganglion. This is the fifth cranial nerve that innervates the entire, the cornea, the facial structures, and it just lays dormant. And then it can rouse its nasty head from emotional stress, trauma, or menstruation. So, yes, it can happen on your lips, which is the most common area, but like I had today, it can happen right on the eyeball. And let me tell you, just like a cold sore is painful on your lips, it's even more painful on the eye. And so what happens is the initial episode mainly affects the epithelium, as we talked about the last couple of weeks. That epithelium is the very, very outer layer of the cornea. And it's the problem is because, it doesn't happen just once, my friends. This comes back. And we don't have any control over it besides taking antiviral medications to kind of calm that stuff down. So when it happens again, it goes dormant. You get it taken care of. It goes dormant. It goes bye-bye. And then all of a sudden it can come back. And then when it comes back, it goes deeper and then starts getting in the stroma. Again, we know when it affects just the epithelium, great, there's no problems. It's just the epithelium. We know that regenerates and does not scar. But once it starts getting deeper and affects the stroma, it gets nasty. And therefore it scars. You got new blood vessels that come in from the limbus. Again, we know there's not supposed to be any blood vessels in the cornea, but here they are trying to heal this infection. And like I say, the problem, it's the gift that keeps giving. There is a 50% recurrence rate that happens within 5 years. So it's a 50-50 shot. Flip a coin whether or not it's going to happen again. So that's the problem with this and why it needs to have such good treatment, whether you've got to be on an antiviral for the rest of your life to keep it from happening again or anything like that. So oftentimes, why does it get so bad? We've got all these urgent care places, and God love them. They do help out the medical community so much because there's way too many people and way too few doctors anymore out there. But people are going to these urgent care facilities for eye problems, and they don't have equipment to look at the eyes. Are you kidding me? So therefore, it's often misdiagnosed or mistreated, and think, it's a pink eye. And so antibiotics don't work, number one. And if they give something with a steroid in it, which oftentimes they do because a steroid whitens the eye, so why wouldn't we try to make our clients happy? Well, a steroid suppresses the immune response, and boom, all of a sudden you've got scars, you've got virus gone wild. I mean, it's the 90s, like virus gone wild in your cornea, not a good combination. So anyway, if you have eye problems, please don't go to an urgent care facility, go to an eye doctor. That's my soapbox for the evening. Question about the eye herpes. If you had cold sores on your lips, can it just pop up on your eye? Unfortunately, that answer is yes. You are at risk of it potentially. Now, generally, it sticks to kind of one area, but yes, it can absolutely come to our eyes. That's why, when you have an outbreak, you try not to share anything. You try to be very careful of where you're wiping, when you're drying your face or anything, because you don't want to specifically put that new viral particles into the cranial nerves of the eye itself. So always got to watch it. It's always a risk. So not only if you touch your lip then your eye, but again, that is kind of why I'm going to back up for just a second because there's been a couple of questions. So if you touch your lip then the eye, that can expose it directly. And when you're a kid, if you have cold sores, you honestly just go ahead and it may get in your eye because kids touch everything. So, I mean, the very odds, but also the cranial nerve that this innervates goes from your mouth to your eyes. So it can travel through anywhere. That's the crazy thing about this virus. So you are absolutely, unfortunately, at risk. So you just watch yourself. And let me tell you, you will know, just like if you've had a cold sore on your lips, you are going to know that you are going to absolutely know if you have something wrong with your eyes because it hurts like the dickens. Question that I've lost you back on how it can get so bad. So basically, it can get so bad by literally the eyes, or it can be misdiagnosed in the urgent care clinics. So that's what it is. And just there was a question. Hopefully, can somebody verify? Am I breaking up, or are we having connection issues tonight?
I hear you just fine.
Okay, thank you so much. So how is it treated compared to pink eye? Well, pink eye is um, the hard thing is, when a herpes virus that affects the eye, like herpes simplex keratitis, it looks like other things. So that's the big problem. But it's a virus. So pink eye is generally caused from a bacteria. So you can't treat a bacteria or you can't treat a virus with an antibacterial. It doesn't work. An antibacterial literally is fighting a bacteria. So therefore, it's no different than why couldn't we use something that works for the bacteria to fight COVID? It's the same thing. And so it's really hard. And same thing with like COVID conjunctivitis, which is a thing. You can't treat that with a bacteria or with an antibiotic either, because again, you're treating a virus, and that's what makes this all so difficult. And if somebody like me has to really pay attention. Do, 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 do. So it's just kind of wild that eye herpes isn't more common. Ironically, it's just like cold sores. People don't like to talk about them. People are embarrassed about it. So it's amazing. I see probably at least 3 to 4 cases a month. Which I mean, I know that it's not a high percentage, but I'm just one person. So it's amazing how it can be out there. So next up is its cousin, herpes zoster ophthalmicus. And yes, nobody wants to say they have the herpes. Okay, funny story, because I have to give these funny stories on Monday nights because my filter is boom gone after all the patients from today. I literally had a student that was working with me, and she wanted me to prescribe her some antivirals because she got a cold sore. And she literally emailed me and I said, I have the herp and it hurts. That was her title of her email. And I'm like, oh my gosh, that's this is so inappropriate. I literally I never forgot it. And this was in 2007. So yeah, those kind of things last with me. You guys wonder why I act like I do. So what does the pain feel like? An eyelash in the eye? I'm going to say it's actually worse. It feels like you've got like a needle going through the eye. It doesn't feel good. If you've scratched your eye, if you've, um, had something where it scratched your eye, caused a little corneal abrasion, that's literally what you're doing because it's affecting the nerves and then it's inflaming the nerves. And the nerves on the corneal epithelium are so sensitive that, by golly, it's not good. So next up, we have herpes zoster ophthalmicus. Again, I call this the cousin because, again, it's another form of the herpes virus. And this specifically is the varicella virus, which is caused from chickenpox. Now, back in the day, we were all exposed before there was a chickenpox vaccine. Heaven knows I exposed half of my kindergarten class. And they used to have chickenpox parties just so we would all get it as a child and not have to get it as an adult because it's much milder as a child. But now we have these amazing things called vaccines. So if you've had chickenpox, you're at risk for shingles. If you've had this chickenpox vaccine, you are at risk for shingles. But what was happening is because chickenpox was still actively going around just by being spread and, affecting our kids, it was keeping us all immune to shingles. Well, now that we aren't exposed all the time to it, we actually, this is why they have now a shingles vaccine, because we need that because of, again, we're not exposed like we were. Our immune system is just like, it's nothing. And then it hits us and yeah, it's something. So if you've ever had zoster, it's very painful. This is shingles. You get severe, severe nerve pain. It is so much worse than a cold sore. You get this vesicular eruption of skin, and honestly, it's just as dramatic as that sounds. Like, these scabs that form are extremely painful. They start with the nerves and then burst outwards through the skin. Again, very painful. It's very swollen, red, and blistered. And again, it commonly lies in the trigeminal nerve, just the main nerve right to the cornea. And it's extremely, extremely painful. So when you have it on the eye itself, you get these ulcers, these openings within the cornea. You get even deeper stromal ulcers. Because there's so much inflammation, you can get a secondary glaucoma. So you can get white blood cells that actually fill the aqueous humor, and that clogs the trabecular meshwork, which creates the eye pressure to go up because nothing can go out, but you're still cranking out the aqueous humor through the ciliary body. And then it can even paralyze an eye muscle, one that helps your eye move. That's what an EOM is, extraocular muscle. So it can paralyze like the lateral rectus or the medial rectus or any of the recti or oblique muscles. And then therefore that muscle is not moving. So therefore now, it can't move outwards, inwards, and you got double vision. So it really stinks. Question, I have refused this vaccine for years. Maybe I should rethink, especially if somebody with eye complications is even more subject to bad outcomes. So yeah, it's, I am one, I will be very transparent. I believe in science. So therefore I definitely believe in vaccines. They're here to help us. Do your own research, make sure it's legitimate research because there's so much bad stuff out there that's misinformation. But again, there is a reason. I told my parents, I'm like, you guys got to get this. And honestly, I'm at risk. So again, why not give a funny story about my life so you guys get to know me? So right before my wedding, which again, I got divorced last year, I literally got shingles. My body was telling me, don't do it, don't do it, don't do it. And so yeah, I've had shingles and it was on my butt. It was literally a pain in the butt. I couldn't sit down. So yeah, that's it's one of those things that I've had it, I've experienced it. Thank God it wasn't on my face or my eyes, but it was still a pain in my hip. At what age do they recommend the shingles vax? It is over the age of 50. Let's see here. So next up, we talked about corneal ulcers a little bit here. So corneal ulcers in the essence of the herpes zoster, bad thing, but also we can get corneal ulcers from other thing. And the most common aspect is corneal ulcers come from misuse of contact lenses. Thankfully, we have come bounds and bounds of where contact lenses were even 20 years ago. They are so incredibly more healthy, but the person has to not be an idiot and actually wear them correctly. So if you're sleeping in your contacts, if you're not changing them as recommended, you are at risk for corneal ulcers. And what happens is the effect of them, they generally cause scarring because they go deep fast. They start in the epithelium and then go deeper into the eye. It's a bacteria eating away the cornea, and so the deeper the location, the worse the scarring. And therefore, if the scarring is near the visual axis where the macula goes through, your vision is dramatically reduced. So again, we don't see it as much from contact lens wear, so which is a great thing. But our eye drop manufacturers last year just had all these eye drops causing these eye infections, and they were from corneal ulcers. And so you just have to be careful and pay attention to what you're using. Talk to your eye doctor. This is why you don't buy contact lenses online from manufacturers that you can't verify just because you want different color eyes for Halloween. Good God, please don't do it. Bad things happen because they're not regulated. They may cause really bad things. So next up, we have band keratopathy. This literally looks like Swiss cheese across the eye. So it's a Swiss cheese band across the eye. So we know Swiss cheese, it looks like it's got little holes in it. And then also it's whitish yellow, I think is what the cheese looks like. Anyway, that's literally what it looks like across the eye. And this is caused from something going on with the tears where the pH changes, or anything like that. So, or the endothelium itself is not functioning properly. So the cornea itself is not at homeostasis. And it just really causes a lot of issues. So you get this Swiss cheese that happens across the cornea that obviously dramatically brings down the vision. And basically the best thing to take care of this, at least it's somewhat treatable, but it can cause its permanent damage. You have to do corneal debridement. This literally means you are scraping the epithelium off to reduce it or to remove it. And that literally, your vision, depending on how deep it is and everything, it may not come back. So this is, we got to figure out, okay, why are the tears malfunctioning, which dry eye is rampant? So what has caused something to go really haywire with the cornea? And that's why you'll have to work with a corneal specialist and things like that. So generally, we do see this more in immune compromised individuals. So they have something else going on that is reducing their individuals. And Gina, I apologize for not having this so late and adding to our nightmare effect, but it is becoming October, which is my favorite month. So why not be a little spooky, right? So anyway, I did take out most of the ones with needles going into the eye. So, or like, foreign bodies, like, the classic fish hook in the cornea. It happens every summer. It's great.
Oh.
Not fun, let me tell you. So I see a lot of this, ironically, superficial punctate keratitis. This is just small erosions. So the epithelium just has all these little dots on it, which obviously reduces the vision. Dry eye is the most common. And the only reason I bring up SBK is because if you're reading a doctor's report that comes to you as they're, referring or what have you, you're working with a service that's working with, that's referring a client to you, most everybody with low vision has dry eye. If you're on a ton of medications, you have dry eye. So it's extremely, extremely common to have this SBK, which that also decreases a patient's vision. I mean, honestly, it is a great idea for you when you're working with your clients and just jot this down as okay, this is an experience factor, because not all eye doctors are me, and I hate to say that, but if you have any patient that has low vision and you're working with them, ask them, are their eyes dry or do they tear? Because they should be on some type of artificial tears. So they need to talk with their eye doctor if they want to get a specific brand, but tell them to start artificial tears. That is going to help them see better. And that is the best thing they can do. Stick with the name brands. The generics had all the problems last year. So I know you might save a couple bucks, but your vision is worth more than a couple bucks. So you don't want to have that issue. Cynthia, your question, is that any medication? I'm not sure. what part that is referring to. This is treatable if that's where we're kind of going. So please know that that is definitely treatable. There's different, prescription meds, but we don't have a cure for it. So it's a constant maintenance program. You can also get, colds can actually cause dry eyes. That's why sometimes your eyes get really red with colds. Oh, basically any combination of medications can cause dry eye. So the more medications you are on, the side effect of being on multiple medications tends to be dry eye, actually. So you want to make sure you're drinking, plenty of fluids, getting your, however much water your doctor recommends for you, because there's some different theories on that. So, just try to do what's smart for you and everything like that. You do see SPK with herpes simplex, and obviously if you get a chemical in your eye, yeah, you're gonna have some damage with it that way. So, you don't want to splash anything in your eye or anything like that. So this one, if you want to talk about nightmares, this is your nightmare scenario here. But recurrent corneal erosions is totally not fun. So we know that any injury to the eye itself or to the cornea is going to cause blur, because all of a sudden a corneal erosion is a corneal injury is going to cause an abrasion. There's going to be a scratch on the cornea where you've interrupted the epithelium, and therefore it's going to be very difficult. So you can get a fingernail, and honestly, the most common people that have a corneal abrasion from a fingernail are new parents, because infants' nails are sharp and they're strong, and their arms go anywhere. So, you can just be holding your baby and all of a sudden, boom, you scratch your eye. It heals because again, the cornea heals fast. Or, if you're walking the woods, if you are, especially if you're visually impaired, or even if you're not, you should have glasses on for that rogue branch that, happens to pop out of nowhere. You don't want to see or feel a branch coming in your cornea. It doesn't feel good. Or a paper cut, So basically it heals quickly, but it doesn't heal appropriately. So therefore the epithelium is just kind of loose. And then all of a sudden, a few weeks later, it's like, oh my gosh, it feels like my eye did it again. Like, what's going on? So what's actually happening here is that when we sleep, our corneas dry out because we're not blinking, we're not producing the tears and everything like that. And all of a sudden, when you open your eye, you basically re-pull off that cornea again. And therefore, you've got a brand new corneal abrasion. So the more and more this occurs, because if you're not treating it and moisturizing the eye appropriately to help prevent this from happening, boom, you now have a recurrent corneal erosion. And the more it happens, the deeper it's going to go each time. And then that causes scarring. So that's why I bring this up. And it's just, we have a lot of parents, or you'll be a parent, or if you've been a parent, things to watch out for with those little kiddo fingernails. They're a weapon. Corneal edema. This is one that literally edema, so is this like pulling a scab off? Yes, but it's recurrent. So it's, yeah, because the scab doesn't really come back, which is the nice thing. It's just, you pull a scab off and it's boom, gone. But this is something that just all of a sudden reoccurs because the cornea doesn't heal appropriately. So corneal edema, if you see the word edema, that literally just means swelling. This occurs because of the loss of the corneal endothelial cells. As we talked about in the last 2 weeks, the endothelium of the cornea, which is on the very bottom, or the inside of the cornea, the very bottom layer, and it touches the aqueous humor. And basically that endothelium is the dam that, prevents how much water is in the cornea. So if you only have a finite amount. So basically, if you lose any of those cells, there gets to be a point where they can't regulate the thickness of the cornea, and the cornea begins to get too much water in it, which reduces the amount of transparency that the cornea has. So there's so many corneal dystrophies that can actually cause corneal edema. You might see the map dot fingerprint, and it literally is called map dot fingerprint because it looks like somebody smudged their fingerprint on the cornea, or they have dots all over their cornea, or it looks like a map of something. I mean, it's a treasure map. You go find your treasure, I guess. But anyway, that's literally what the cornea looks like. the cornea becomes unstable and transparency is then lost. Do I talk about that? No, hold on. I'm going backwards here just for a second here. So the other one that really has a lot of corneal endothelial, okay, there it was written right on the slide and I missed it. Okay, so the big one, you got to really, really watch the spelling. It's called Fuchs, F-U-C-H, not F-U-C-K. I have had many students mistake that on a test. I'm like, I know what you type here, just like me. Anyway, so it's the loss of endothelial cells. And again, that really causes a lot of swelling. There are cases where these patients become extremely visually impaired and everything. The worst treatment, which you can kind of imagine why it's not the best, is either, so sometimes in the morning, if your vision's really blurry, you can take a hair dryer on your eyes. I know that dries them out, but it also takes the water out of the eye as well. So it does help. So you're kind of evaporating the extra water out. Again, these sound crude. We don't have any good real treatments for it. The other thing is using saltwater drops, which again sounds crazy and painful, but you're using these saltwater drops to, again, use the salt to pull the water out of the cornea. So next up, we have bullous keratopathy. This is different than band keratopathy. Band keratopathy really is not that painful, where bullous is. That's the big deal here. So you basically have there's some type of damage to the cornea, and generally this happens from some type of internal surgery. The surgery, something with it goes wrong. And so the cells lose their ability to remain clear. They become very edematous, they swell, and then you have the endothelial cells spread out, and then therefore, because the endothelium cells they're dying on you, then you're getting more swelling to the cornea. And then you can also even have epithelial edema. And because we know that all the nerves go into the epithelium, it's very painful because of the epithelium, they have all those nerve endings to, again, protect us. So if those nerves swell, or if the epithelium cells swell, it becomes very painful to the nerves. And obviously that causes a lot of blur. Generally, there's no good treatment for this besides a corneal transplant. Then, as I alluded to before, we have chemical injuries. These are going back to chemistry or science class. These are acids and bases. If it's an acid that tends to get in the eye, that can obviously cause, they're most likely accompanied by a foreign body. So you have extensive burning. And this is like your sulfuric acid, your hydrochloric acid, nitric acid, acetic acid. So all of those basically just burn off the front of the eyes, which is great. So that's why you have to flush them so quickly. Now, the problems if you get a base or an alkali in, this is your sodium, potassium, ammonium, calcium hydroxide. The problem with these is they penetrate deeper. So they really adhere to the corneal and conjunctival tissue, and actually you get a chemical reaction going on in your eyes because they interact with the cellular proteins, and that causes the cornea to instantly become opaque or instantly scar. So, this is where, it's so important to wear the right construction equipment because, again, this is generally who does it. Or, you've got these, okay, I'm going to make fun of my own sex here, but, guys out there trying to do their own thing, being smart, like, oh, I got this. I can do anything and nothing's going to happen to me because I'm doing a do it at yourself project. Want to make somebody proud. And then you don't wear the proper equipment and boom, this totally happens. So yeah, just again, you may see vision impairment caused from chemical injuries. We also can get chemical energies from excuse me. We can also get damage to the cornea from radiant energy. This is energy from some type of waves. Generally, it's like the sun. So ultraviolet, yes, you can get a sunburn on the eyes if you're out there too long, but generally our eyes are too sensitive to it, so that doesn't really happen. But tanning beds are a big factor. So if you still tan, wear your eye protection. Number one, the skin around your eyes wrinkles so quickly from a tanning bed. Why would you want to be a reason to get Botox early? So anyway, basically the ultraviolet light is absorbed in the cornea. It burns off the cornea, giving the cornea essentially a sunburn. The more it happens, yes, it can scar. The biggest problem is an infrared burn. So like this year we had the great North American solar eclipse, which was really, really cool, but you had to use the proper eyewear to look at it because, this is the only time we can actually look at the sun and it doesn't hurt our eyes. But if there is any part of the sun coming through, your eye literally is a giant magnifier. We'll talk about that in optics, but you are making all this light waves converge onto the retina through a giant 60 diopter magnifier. That's really strong. I was able to burn a leaf with a 3.5 diopter one for a TikTok I did earlier this year that basically showed how quickly organic material can burn. So if I was doing that with a 3.5 diopter, imagine what a 60 diopter lens would do to your macula. And because again, when you're looking at something, if you're looking directly at the sun, basically the sun is so incredibly intense. There's so much heat coming off of it. When you look directly at it, you're aiming your macula right at the sun, and therefore the light rays are converging right on it to burn it off like a giant laser. So you have permanently reduced acuity because now you've burnt your macula. And yes, we saw about 6 or 7 patients out of our entire practice that had this happen this year. So they have reduced vision because they looked at the darn eclipse, even though there was so much information out there. So yeah, anyway, so where do computers and cell phones fit in here? First off, with computers and cell phones, they're certainly not as intense as the sun. So therefore, number one, that's a great thing. We know that blue light can cause damage because again, blue light is closer to UV. UV is what gives us sunburns, things like that. So that's where, the thought process, and that's how blue blocking glasses came into existence. The jury is out whether or not the actual blue light causes any damage. We don't have any long-term studies because again, these type of screens are actually still, really relatively 15, 20 years that we've been on them all the time. So we don't, first off, know. Now we do know that, this white light, this is an awful slide to be showing you because of the white, is going to affect your melatonin and that will affect sleep. So we do know that actually happens. But that's as far as we've been able to go right now. Now, do glasses really help protect our eyes during the eclipse? And that, as long as you are wearing the actual, I don't remember the actual organization that certifies those glasses, but if you, the problem with it, if you didn't buy them from a reputable source, there were a lot of fakes out there too, which makes those eclipse glasses even more dangerous. So this is where it's really, detrimental to use glasses that don't have the proper protection. Welding glasses, yes, those are absolutely okay if you are a welder because again, it's protecting you from kind of the same type of thing here. So basically, you are able to look at the sun during an eclipse with those glasses. Generally, you want to go a max of 20 minutes, but the eclipse doesn't last that long. The totality only lasts about 3 minutes. And if you are in a place of totality, as long as no light is coming from the sun and it's completely dark out, you are able to take off the eclipse glasses and safely look. But the moment the sun starts peeking through, you have to put the eclipse glasses back on. Sun gazing, I'm not exactly 100% sure, but I do know that there are folks that, do like to gaze at the sun. The more you look at the sun, obviously, it's going to cause problems and you're going to burn the macula no matter whether we're having an eclipse or anything. I mean, I know I'm pretty, I'm pretty light sensitive. So the moment I have sun in my eyes, I'm like, oops, sunglasses on, got to protect them. And I try not to look at it. Is the damage primarily on the retina? It is on the retina. So that is literally what is being burned at this point. So the retina is kind of stopping it because the light is able to come through the eyes and the retina is the last is the point of where it stops the light going through, so it doesn't go any further back. So yeah, it goes to the cornea, it goes to the lens, it goes through everywhere. So X-rays can also cause it because, again, we're talking about different wavelengths that can cause different problems. So when you have an X-ray, this is a shorter wavelength, and that can cause, if you're exposed to X-rays and you're not wearing the proper protection. So yeah, it can cause increased eye pressure by damaging the trabecular meshwork. That's where glaucoma comes in. You can have skin death. You can have your loss of eyelashes, or you can have an inflammation of the aqueous humor that creates like a lot of white blood cells. That's what iritis is. So there's a lot that can actually happen here. Now, next up, we're going to go into the anterior chamber. So those are all things that are kind of isolated just to the cornea here that end up causing blur. In the anterior, yes, question.
Oh, I'm sorry, Dr. Johnson. Are you saying when a person has a standard X-ray, one should wear eyewear, or is that just if you are having some kind of neurological X-ray?
So it's basically if you are exposed to X-rays on a daily basis, just the limited X-rays that you get, just to check something out, you're fine. But it's the X-ray techs and things like that. X-rays are more prominent when we fly. And so if our airplanes didn't have the proper protection, we'd be exposed to X-rays that are just, naturally occurring in the outer layers of the atmosphere. So it's that type of thing. But your standard X-rays, no, not a problem.
Okay, thank you.
You're welcome. So in the anterior chamber, the first up that we're going to talk about is a hyphema. A hyphema means literally, instead of being clear fluid, aqueous in the anterior chamber, you have blood. And red blood cells, as you know, you can see it, you can't see through it. And so therefore, you can't see. It's blocking your vision. So vision is either blacked out or blurred depending on how much blood. If there is 100% blood in the anterior chamber, you are not going to be able to see through it. But generally, it's not 100%. So therefore, you can see through it. It's just not a clear image. Blood can actually scar the back of the cornea. The endothelium is sticky, so therefore it can scar that. This most likely occurs from some type of tear in the iris because the iris does have a lot of blood vessels to manage both the sphincter and the dilator muscles. And so that can happen. So some type of trauma is generally what can happen. So like a fall or something like that is where it can cause that tear in the iris, car accident, things like that. So you heard me talk about the term iritis or uveitis in the couple slides prior. This is literally an inflammation within the eye. So the eye is fighting something. We don't, sometimes we don't know what. If there's an autoimmune disease like Sjogren's, like rheumatoid arthritis, or lupus or anything like that, you're at risk of iritis. So if there's an autoimmune disease, sometimes the immune system just goes crazy. And therefore, you can get an inflammation without any reason inside the front of the eye. And when you have white blood cells that are now in the anterior chamber in the aqueous, you're going to get blur. That aqueous is supposed to be clear, and white blood cells are, just as the name pronounces, they're white. They're smaller than a red blood cell, but there becomes a lot when there's immune response. So because you have all these white blood cells hanging out in the anterior chamber, you're going to get increased eye pressure because it's going to clog the trabecular meshwork. And so not only is it the immune system, but any type of corneal injury. So something going on with the cornea or an eye infection or something like that can also make this happen along with the immune system. Now, another one that's not really an eye disease, but something that's congenital or something that you're born with is called iris hypoplasia or aniridia, which is iris hypoplasia. This basically means that the iris does not form. So you're born without an iris. This oftentimes is congenital. When you see the words congenital, it means you're born with it. It happens bilaterally, which means it happens to both eyes. And it is a hereditary thing. You inherit it from your parents. It's genetic. So if you have this, your vision is oftentimes reduced There's extreme light sensitivity because now that aperture of the iris is not there to control how much light is happening. And because the eyes are always light sensitive, and the eye, when it's developing, is just inundated with all this light, so the eyes are constantly moving, you develop a nystagmus, which is a constant movement of the eyes. So oftentimes this is correlated with other types of hypoplasias. Again, that's irregular or incomplete development of both the optic nerve or the macula, which is bad. You are more prone to cataracts. We'll talk more about cataracts because basically with cataracts, they are formed from UV, the UV damaging the cellular proteins that are within our lens that make it go cloudy. So you get cataracts much, much earlier. And they're also, for whatever reason, can be corneal changes because it's all interrelated, it's all interconnected. So if something doesn't develop appropriately in the eye, then other parts of the eye also do not develop properly. So that's what we see with aniridia. There are different ways. I did have a client that went through and had a lens exchange. So they had cataracts, and the lens that they had implanted actually had an artificial iris painted on it to kind of help them out with some light sensitivity. So next up, we're going to keep on working backwards, and we're going to hit the lens of the eye. And I have in here, well, this is where we get some surgical stuff, so I again apologize about the nightmares, but 100% of the population will experience cataracts as long as they live long enough. So at some point in their life, generally, after about the age of 45, you're at risk of having cataracts. I had a 42-year-old today that had cataracts. I'm sure I've got them developing because, again, the lens grows like an onion. The biggest thing to know is not everyone will need to have cataract surgery. So cataracts is still the number one cause of blindness in the world. I'm going to back up, and I've got a question. Can I ask about nystagmus? Should we think of nystagmus as a symptom of a lot of different eye conditions? Basically, yes. That is generally caused from a lot of different eye conditions, whether it's, yeah, and we'll talk more about nystagmus. Please know I'm just not throwing it out there and then we don't talk about it again, but we do end up talking about nystagmus quite a bit. So yes, and Kimmy, I'm not sure I'm quite follow. You have is it an 18-year-old who has them? Has the cataracts, can't have surgery because he has diabetes. So yes, if diabetes is not controlled or anything, yes, you absolutely cannot have you can have cataract surgery. I mean, it's one of those things, the body has to be stable if you're going to do some type of operation on it.
And that's what he's struggling with. He cannot have the surgery because his diabetes is not controlled. And so he just has very low vision as a result of the cataracts at 18.
I know it's crazy. So yeah, obviously if metabolism is is off because of something else, yeah, you're absolutely correct. That it's awful. And I have patients that it's just like we have, dementia patients, and then if they're in a nursing home or a memory care facility, they can't have cataract surgery, which again, vision loss has been now correlated to making dementia worse. And Medicare, Medicaid, things like that don't pay for cataract surgery in an assisted living facility. So it's awful. It's really hard. So that's why I say if you're going to get cataracts, just get them out as soon as the doctor tells you to. Don't wait. It's not worth it, especially in cases like that. But basically, like I say, this is an opacity within the lens of the eye. There's 3 generally adult types that we'll kind of put here. There's nuclear sclerosis, there's cortical, and then there's posterior subcapsular. So it just depends on what part of the lens is being affected. So with nuclear sclerosis, this is literally a discoloration of the lens. This is a yellowing of the lens. If you have a dog and you're able, see, or even a cat, you can see nuclear sclerosis within your dog or your cat. They're all going to have it too. This can cause diplopia or they may have tri or quadplopia, which makes it even fun because it just distorts the light coming through. I mean, it's generally it makes your vision very, very foggy. It can cause a major refractive shift, so it can throw somebody from being farsighted to nearsighted. Generally it does do a nearsighted shift with it. I have seen somebody that had a 4 diopter shift in just a year. I mean, it's amazing how it can just change how the light is being bent in the eye. So when you hear me say refractive shift, it's just a change of how the light is bent within the eyes. And again, we'll talk about that more. So Lisa, so if doctors tell you the cataracts are not ripe enough and they don't want to have them taken out, is that a real thing? Oh God, that's a loaded question. So number one, I hate the term ripe because that's an awful terminology. But again, they use it because the lens grows like an onion. The onion is, when it's ripe, it's, or if it's overly ripe, it's yellow. So honestly, if it's affecting your vision, the problem is I do know, unfortunately, this is where the ethics of my profession get in the way. If a doctor wants to sell you glasses, they're going to sell you glasses and not recommend cataract surgery. So there are folks out there. So you have to do your own research. And I hate to say and throw shade on my profession, but there are some docs that are literally just going to be like, no, we could just fix that. We just need to change your prescription. Honestly, I feel like I recommend cataract surgery so much earlier because it's like, it is not worth it. The sooner you have cataract surgery done, once you're eligible, there is an insurance requirement that you have to be a certain point because otherwise it's just considered cosmetic just to help your vision because they're basically changing completely the refractive powers of the eyes. So I know this is a little tangent and everything, but yes, to easily answer your question, yeah, there are some docs that will wait until it's longer, but honestly, it's easier. It's a very less complex surgery. Once they're ready, if they're ready when you first recommend it, it's an easier surgery to have done. There's less risk of complications, and we all know how important sight is because that's why we're here to do rehab on it. Just get the cataract surgery done when they first recommend it. So. Anyway, that's my soapbox for that particular one. So hopefully that did help here. Next up, we have cortical. Cortical is another type of cataract. So rather than the nuclear sclerosis where we get this clouding, cortical is more looks like spokes of a bike. You can have spokes in the front, the back, so anterior, posterior. And it basically, this one is really the heavy hitter. It causes glare. So it's not a lot of visual degradation where the acuity or how the quality of somebody's vision is, but you literally get more glare. So therefore, a lot of problems with night driving and things like that. But again, I have the least amount of visual effect because it's just more glare. So daytime, it's fine unless you're in a really bright room or something like that. We also have what's called posterior subcapsular cataracts. This is right on the back. It is a very small, opaque part on the, a blockage on the posterior part of the lens. It's often exacerbated in diabetics. Posterior subcapsular cataract can be called PSC. It is the most visually debilitating. Now let's think about this. Okay, the cataract, you've got this small opaque part that is right in the center of the back of the eye. And so why would it be difficult with reading? What happens when we read? The iris itself gets smaller, and now all of a sudden the light isn't getting through. So you're blocking all the light getting back to the eye, and it drops the visual acuity. That's why this particular cataract makes it so difficult to read. It also causes more glare at night because as the pupil opens, it causes more light scattering. And then just like when it's difficult with reading, what happens in bright light? The pupil constricts again, that sphincter is activated, but then now you've got this opaque structure, this posterior subcapsular cataract, actually blocking the light that's coming in the eye. So therefore you have reduced vision in bright light, reduced vision while you're reading. And again, you do get also glare at night because it's causing more light scatter. So this is the most visually debilitating, causes the most problems when it comes to a patient's vision. Now, other forms of cataracts, you can also have congenital cataracts where it happens basically at birth. So you're born with this cataract, something happens in the birthing process that you do get there are cataracts that are also genetic that you can be born with. And then you can have some type of traumatic cataract, whether it's an injury or anything like that. So yes, you can absolutely get it from surgery, from damage to the lens, anything like that. So can I tell which kind of cataract somebody has? Yes, I can absolutely, through a microscope, tell exactly what type of cataract I have. And my diagnosis, like Medicare and Medicaid, all the vision or all the medical insurances require me to specify what type of cataract a patient has when I'm diagnosing. Again, I don't do surgery. I'm an optometrist. I'll explain the 3 O's later as what a difference between an ophthalmologist, optometrist, and optician are. But yeah, there is absolutely a way to tell the difference between which one each one is. So, and yes, those would be included on an eye report. So yes, absolutely. Great question there, Kimmy. Great follow-up. So with congenital cataracts, this is again a clouding of the lens. It looks a lot like the age-related one. So if it's my first time seeing an adult, I've got to determine there's a few little characteristics that, you know, maybe it could be congenital, but it's really tough to tell if it's my first time knowing it unless the patient themselves has already been told. So again, it's very similar to adult cataracts, but the reason why it's more visually serious in kiddos is because it affects the retinal development and can cause amblyopia. So the brain is just going to turn things off. If both eyes have it, that brain is never going to know what clear vision is. So therefore, that part of the brain can never actually develop. So it never knows what crystal clear vision is. And, you know, once you've hit that tender age of 7, vision development's done. I mean, you are set for life at how the best possible vision you can actually get. So when we do treatment of congenital cataracts, they can be all the way from aphakic, meaning there's no lens there, to pseudophakia, meaning there's a fake lens implanted in there. The problem with a congenital cataract, if it's taken out as a really young kid, they can't implant an adult lens in there because the eye is still growing. So they have to wait till an adult, and then they have to treat it with like contact lenses or something, or glasses. So at age 7 is when the retina is fully developed. Yeah, absolutely. The visual cortex and the retina are fully developed by the age of 7. And there's very little plasticity or, you know, little changes that can be made after that point. It can still change, but the really power of the child growing, the eye is basically, it is what it is at the age of 7. Again, that doesn't include glasses changing and all that fun stuff, but just how well we can see is determined and formed by the age of 7. So there's a million different types of things that can cause congenital cataracts. I don't want you to know this list. I want you to know from this slide, there's a lot of things that can cause congenital cataracts, okay? So you can be born with something, you can get it genetically. That's literally all I want you to know. I will never ask you, and again, this is being recorded, so you can hold me to it. I'm not gonna ask you, okay, what are some syndromes that can cause congenital cataracts? So how do we remove them? So yes, cataract surgery is so common in the United States. The removal becomes the option once the vision or the quality of life specifically is being impaired. It's a 2.5 millimeter incision. It's an outpatient surgery that lasts between 8 and 12 minutes, actually. It keeps getting faster because we get better with technology. They do this thing where, you know, they go in and they actually do what's called phacoemulsification. So they have to use an ultrasonic probe to break up the lens within the eye. And because they can't just pull it out through the small of a suction cup, and then they literally vacuum it up. So as they break it apart, then they vacuum it out, and that's where they implant the artificial lens. So I have this, you know, this basically graphic that shows making a clear corneal incision, so a small incision. They cut off the anterior capsule of the lens. They go through and use an ultrasound probe to actually break up and help remove the lens and vacuum it all up. It's a dual action, so it's not a big suction probe. They can't cause problems with the vitreous or anything. And then they insert an IOL, an intraocular lens. That's what an IOL is. And in the IOL, it's all folded up in a tube when it's put in, and then it unfolds and goes in its spot and stays there for the rest of a patient's life. It is absolutely remarkable. Again, we didn't really have this until the 1960s. So it's relatively new. 1949. See, I can't even remember my years. But these replaced aphakic glasses, which are huge because aphakic glasses are really just, think of 5 to 6x magnifiers that you have to wear on your eyes. And oh my gosh, if you've ever looked through a magnifier and just kind of, bounce your eyes around, those images move tremendously here. So it minimize, the whole goal of using these intraocular implants from cataract surgery, it minimizes the use of spectacle lenses for distance after surgery. And they, again, are placed within that lens capsule. So they leave the actual lens capsule. They just remove all the inner parts out. And they now have lenses that are accommodating. They also have lenses that are for stigmatism. So again, reducing the need for glasses afterwards. So that's why the insurance was like, okay, there's a part where it's cosmetic, or is this medical because it's affecting your quality of life? So that's where, for an ophthalmologist at least, they are going to want you to get it out as soon as possible because then they can do surgery on you and make money, obviously. And again, then you're going to have less risk. So again, that's kind of where my standpoint is, even though I may lose a glasses sale. I don't care. I do this for my patients, again, I have to live, but I'm doing just fine. But again, they have different upgrades now, so you can actually upgrade. Full disclosure, my dad was like, I've worn glasses my entire life. I will just deal with it. I'm not going to pay for an upgrade and things like that. So what if you don't have cataracts, but you do have astigmatism? Can you have surgery for that? So yes, there are different things that you can do. They are actually doing where you just fully pay out of pocket. I had a friend that paid 10 grand for her to have cataract surgery younger than she was supposed to, that took care of her astigmatism and everything. So yes, you can absolutely do that. It's just really expensive if you don't have medical to pay for it. So, or they can just do LASIK surgery or some type of refractive power surgery. And we'll get into that later too. So once they do cataract surgery, again, they're leaving that capsule. So if it's a hazard to drive, absolutely, there is absolutely a criteria. I've had to tell people, you haven't had an eye exam in years, you're still driving, and your vision, you are basically legally blind because of your cataracts. Do not drive. You need to get these out in order to drive because I will not pass your driver's exam. I will fill out the form exactly what you got here. I don't lie on it. So yes, absolutely. Hazard to drive is one of those things where it's definitely quality of life. And that they do have the vision qualifications at that point. So please know that.
So obviously I'm talking about myself, not trying to age myself, but I don't think I have cataracts, but I have astigmatism so bad that at night I cannot see, especially with all those cones all over the place and all those reflectors.
Mm-hmm.
Right. So can that get paid for? I'm curious, like doing business with you right now.
Doing business. Well, number one, I don't do the surgery. So,
but no, can you do it just for the astigmatism or do you have to have the cataract?
You'd have to have the cataract. We can take this offline so I don't want to go into
Okay. Just
personal information or anything. Continue this offline. Shoot me an email and let me know some more specifics about you. So, because I'd be happy to dive in a little bit more. So let's see. So capsular phimosis, that's the next part. This is very common. It's a side effect of having cataract surgery. So basically this is like a secondary cataract. So when they implant the actual lens, again, they leave the natural lens capsule, but they take out all the innards, put in the artificial lens. Well, then basically the secondary cataract can form. The capsule tries to regrow back. And so you can get diminished vision and glare. And again, even though they've made a lot of modern advances in lens design, this basically it still happens. So this film kind of grows over the back of the lens, and then they use a laser and pow, 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 and it's all cleared up. So it goes right away. So again, this is not something permanent, but you know, I bring this up, and it's funny. You know, you'll see if you get the opportunity to observe me, I tell my patients exactly how it is. Maybe I have more freedom because number one, I've worked at the VA, so I'm more blunt. I don't know, but I also feel I'm going to advocate for my patients because that's what I'm there to do. I had a legally blind patient. Again, he's always seen 2200, and he came in and he's like, my vision just feels off. And he had an eye condition that the vision should not be progressing, but he did just have cataract surgery. And I'm like, do you mind if I just take a look at your eyes? And I looked, and he had just gobs of this capsular phimosis on the back of his lens that all the doctor needed to do was, you know, take this away and get him back to where his vision was. And the doctor refused to do it because, well, he's already visually impaired. What does it matter? His vision went from 2200 to 2400. That's less the vision. Give this man as much vision as he wants. I don't know if it was because he was a man of color. I don't know. But I wrote a letter to that doctor being like, hey, dumbass, I'm sorry. Hey, doc, please reconsider doing this because you are, come on, there's no need, and you're going to get paid for doing the surgery. So come on. Anyway, soapbox. I get on a lot of these. I get passionate. Okay. Anyway, so again, we use that laser and get that taken care of. Do you ever wish you could be doing surgeries? Yes. And actually my profession is working on doing these specific type of surgeries because we don't have enough ophthalmologists. It's crazy. We have an ophthalmologist shortage, and yet ophthalmologists are trying to stop optometrists from doing surgeries. Oh, it's so fun. Gotta love politics, right? Actually, those kind of politics I'd rather deal any day than our presidential politics, but that's another story. So yes, I'm hopeful that someday before I retire, I will be able to do these type of surgeries. Believe it or not, 20 years ago, 25 years ago in the state of Michigan, I was not able to prescribe medications. And 30 years ago, I was not able to dilate my patients. So that's how far we've come in a short period of time that ophthalmologists have been trying to stop optometrists from taking care of our patients because they feel we're going to take over their. I don't want to do full-on surgeries. Are you kidding me? No, but there's no reason I can't use a laser. They learn this at a weekend course, really, and they're probably drinking when they're doing it. Anyway, I digress. Okay. So let's go up to the vitreous here. So we've done the lens, we've done the anterior chamber, we've done the cornea, but now we're going to go back to the vitreous and go in the back of the eye, keep on moving our way back. So with this, we have what's called a vitreous hemorrhage. This is mostly caused or most commonly caused by a vitreous detachment. That vitreous is very unique. Again, it's a gel-like material that basically, as we age, it liquefies. So the more likely it is to liquefy as we age, is it in whatever decade of life. So for me, I'm in my 40s, that's my 5th decade of life. There's a 50% chance that my vitreous is liquefying and degenerating. So again, and I can tell you my vitreous is degenerating. And again, it's something we all go through. But what also can cause the vitreous detachment or a vitreous hemorrhage. Thankfully, I don't have the vitreous hemorrhage. That's blood in the vitreous. Whew, I got off on just talking about a vitreous detachment. But basically, when the vitreous does liquefy and detaches, if it pulls a blood vessel, it causes bleeding to happen, which again then fills the vitreous with blood. And because there's no actual blood vessels in the vitreous, it just takes a long time for the retina to reabsorb that blood. Other things that can cause vitreous hemorrhage is diabetic retinopathy, some type of vein occlusion in the back of the eyes, some type of tear to the retina, or obviously trauma. So you get this very hazy to light perception acuity for the patient, depending on how much blood is in the vitreous. Very similar to a hyphema in the anterior chamber, a vitreous hemorrhage, at least this one says where it's located. So if you're like, okay, if I say a question, okay, where's a vitreous hemorrhage located? It's in the vitreous. That's a question we all would want on an exam. Probably won't happen, but you never know. Who knows what I'll be feeling like in a couple of weeks. So next up, we have the optic nerve. So going to the back of the eye now, we have optic neuritis. Optic neuritis is the first one to talk about. This is some type of inflammation of the optic nerve. And the most common thing that causes optic neuritis is actually multiple sclerosis. It is oftentimes an eye doctor that ends up diagnosing multiple sclerosis because of optic neuritis, because it affects the vision. There's a sudden reduction of vision. It is definitely reduced. There can be pain upon eye movement just because of the inflammation of the optic nerve, just ends up adding extra pain. The pupils don't react because if there's visual processes or visual impulses aren't going through the optic nerve appropriately, that affects how the iris is functioning. And you do even get a loss of color vision depending on where the inflammation or the swelling is happening within the nerve. So again, optic neuritis is very much one of those things that if you ever see me say something that is most common, generally that means it's most commonly also to be a test question. I will be very honest with you on that. Next up, we have optic atrophy. Optic atrophy is a loss of nerve fibers within the optic nerve. There can be primary optic atrophy where you're born with optic atrophy, where the nerve is formed initially, but just all of a sudden part of it dies. We don't know why. Generally, it causes a large central scotoma. So, especially primary optic atrophy, if it's just the optic nerve, not like glaucoma or something like that, it's just the vision is just blurred. There's no problems with the peripheral vision or anything like that, because again, it's the central part of the optic nerve that has the atrophy, not the peripheral part of the nerve. Central part of the optic nerve carries the macular fibers to add for more protection. So these patients that have optic atrophy are very photophobic. If you see photophobic or photophobia, that is the term, what means light sensitivity. It's not a fear of light. You're not afraid of light. It's just you're light sensitive. If we break that word photophobia down, always cracks me up. You have altered colored vision because again, the nerve fibers are affecting the macular fibers that are going through, and it often commonly occurs without an underlying cause. So we don't know exactly what causes it. So that's enough new terminology for this evening as we go through it, and I've rambled long enough for you tonight. If you haven't done exam 1, that is due again tomorrow. So please make sure you do it. This current section that we're on, Blur 1 and 2, is there's 2 modules. So the discussion portion will open next week, and that is due October 6th. The quiz over part 1 we went over tonight is due September 29th. So it's next Sunday. Next up on the research project, we've all assigned our topics and done all that fun stuff, but now it is time to start thinking about, okay, what sources are we going to use? And so I want to see just 5 of your sources on like a Word document or some type of document that you can upload to the e-learning Dropbox. And I want them to be in APA format. So this is your first option to literally, if you've never done APA before, you can be like, okay, this is my source. This is where I want, this is how to put in APA formatting so you can get a little help. APA formatting does include alphabetical order. So there's plenty of websites, whether it's through Western's libraries. I think Purdue has a great website that really can help you put it in. Like if you put the link to something in, it's going to find it for you and put it in APA formatting. So there's a lot of different ways you can do this. I just want to see 5 draft sources for you, again, in APA format. And again, that is due next week already. So next Monday, those are due. And again, you don't even end up having to actually use these, but I just want you to practice writing something in APA formatting. Again, nothing else. It's just literally just your 5 sources. That's all it needs to be on there and uploaded here next week. So if you don't end up using these sources, great, but at least I know you're starting to know how to research. If you need help with research, please contact the library. We have so many wonderful staff at our libraries that will really help you out here. And then finally, it's already midterm time. So October 5th through the 11th, you have to take the 2 parts of the midterm. It'll be over these 4 weeks of basically the anatomy of the eye as well as all things blur. So the next 2 weeks. So it's those 4 things. So that means we will have another study session on a Friday evening that if you guys want to go from there. Teresa, I got to write it this week. So the time limit, I don't know. So I will get you much more information next week and we'll talk about that more. So, each one generally I want to say is about 45 minutes because it's kind of a class session is how I kind of leave that. Because generally if I had you taking it literally sitting in front of me, that's kind of how I was. So that's what I'm kind of thinking in my brain, at least right now. And everything like that. So class sessions are generally 50 minutes. So it would not go for that. But because it's broken into 2 parts, you'll have part 1 that'll have 45 minutes. The other part is 45 minutes as well. So again, we'll kind of see where that is. And we'll give you a little update here next week. So again, I'll kind of have the breakdown of kind of what to expect and everything. And again, it will not be just parts 1 and 2 on part 1. That'd be really nice of me. I'm not that nice, unfortunately, because I do want to make sure you've learned some material as we're going through and, committed some of this to memory. So there won't be a certain section, broken down or anything like that. It's just kind of a hodgepodge all put together. So next study session will be, if I look at my calendar really quick, that would be, oh my gosh, where's my calendar? There it is. Okay, the new iPhone update is not my friend, just so anybody knows if they were wondering. Don't recommend it right now. So I'm kind of looking at October 4th, which would be a Friday. That's what I'm kind of looking at doing the study session again here. So kind of do it like we did last time and everything like that. So that should work out pretty well. If something changes or anything like that, you do have more time to take it because I have it open the 5th, which is that Saturday, through the 11th, which is the following Friday. So we'll just kind of see whatever works out best. But generally, I think the 5th will work out great. And we can do the 5th. Erin Lynn, sorry, I probably have not opened that yet. So thank you for the reminder. I will get that opened. That will be opened here. If it's not tonight, it'll be opened by tomorrow evening. So we'll get everything uploaded and get that all taken care of. That's the one thing I forgot to do. I did everything else yesterday to make sure. So again, thank you. I'm human, so thank you for your grace and understanding that here. So do we have any other questions?
Johnson, I'm a little confused about the quiz. Was there a quiz that is all, I know there was one quiz. Was there a quiz that also has to be completed by tomorrow?
So the
or
exam
that was-
1 is due tomorrow. There was a quiz 2 from last week's lecture material that was due yesterday.
Oh my goodness, I got confused with that also. So that's already closed?
Yes, yep, that did close yesterday. So yeah, we actually did a long talk on that last week and went over those dates and everything. So just make sure you're keeping up with dates because that's really it's a lot. But I mean, the nice part is don't forget the bottom 2 are dropped. So just try to keep up with it. Again, Sundays are a due date thing. Watch the calendar, watch these PowerPoints, because again, that's why I try to summarize all of this here to try to make it as easy as possible, because I know there's a lot of dates. It's not just this class and everything like that. So just try to keep up with that.
Thank you.
Is it fair game to ask a question about the last test? Or is it?
It is too early to ask about the last test.
Okay, and I just wanted to make sure that Gwen knows there's a test that's coming up that's due.
Oh, yes.
Okay.
Yeah, that
That's
is,
by tomorrow at midnight.
yep, tomorrow at midnight. Yep, you got it. So don't start it right before midnight, because midnight or at like 11:59 p.m. It closes. So if you're done or not, it's going to, if your time, even if you still got time left, it does shut it off at that. So keep that in mind. And also, if you're in a different time zone, everything is Eastern Standard Time.
And then 67 grades and then exams.
Yes. So they don't let me separate between whether it's quizzes or exams. So just watch the exam or the quiz title. It's called Exam 1. And I think I have it under course resources, I want to say. I don't have that offhand. But yeah, it will be under, it's listed under Exam 1. Question, will we have access to incorrect answers on our exam once completed? You will have access once everybody has completed. We do have a couple folks out with an emergency right now. So they will be, honestly, it does take me, I won't have these probably graded until next weekend anyway, just with how my weeks are. Weekends are when I really kind of dedicate my time to this class. So my goal will be to get these to you next weekend. Or that's my aim for that. So yes, you will able to see, like, once the grades are posted, you will be able to actually go in and actually look at it. So you'll go under like grades, click on that, and you'll have access to see what exactly you did. Any other questions?
Dr. J, do you just teach this course once a year?
Yes.
Oh, okay. How lucky.
So yes, it is just the fall. So Cami, have a great night. So yeah, it's just in the fall when we do this. I've never had this many students. This is my first time having this many, so it's been a lot of fun. And yes, Chester, absolutely. Eye safety. Just remember, I don't want any you guys seeing me for any of this stuff here. That's for sure.
Good night, everybody.
All righty. Well, everyone, have a great night. It's been absolutely wonderful
Right,
with
thank
you.
you.
If you have any questions, of course,
Good
shoot
night.
me an
Thank
email,
you.
okay?
Thank you very much. Good night.